Hvis det ikke er noen spørsmål, så, I think I would really like to comment on the proactive outreach and the value of that. And I think we tried it in Norway twice. After the tsunami, we tried to use the general practitioners, the GPs, to reach out. But the line from the Minister of Health down to the practitioner was really long with a lot of different people in between. So the communication was really bad. But those who got that proactive intervention from the GP were very satisfied with it. And now that we realized we had more crisis teams going and we could use the crisis teams, even more people say that they were confident with that. And I think the problem is with an acute intervention, or I don't know what you call acute, but if you're thinking about the first day or the next day, and I guess that's when you plan to have this to gather them in the psychiatric units or something. It sounds weird to me, but it seems that's what you're planning of. I would like to see that in practice, how that works. But the problem is not the first day. The first day and the second day, then they need psychological first aid. They need to, as they were after Utøya, they were collected in a nearby hotel. And, you know, what they tried to do there was to try to calm them down, give them food, and try to find out how they could send them home, you know, psychological first aid, basically. But that's not what I'm talking about with proactive outreach. It's only the day after that, or the day after that, the day after that, or the next week, that they realize what their problems are and what kind of information they don't have. What they want to know more about. They want to know what happened to that. When I was there, I don't realize what happened to that person. Can anybody help me? You know, and they don't know who to contact about it. So that's when they need the proactive outreach. One person that call them and say, I'm here, come here, have a personal meeting. I will help you to find the right people and find the information. Of course, then you need those contact persons or the crisis team to know where they are going to gather their information. But at least then you have a system. Because if you have an acute outreach the first day and the next day by specialized health services in some kind, and then you just send them home, then that's where the problems are going to start for you, I think. And I'm really curious if the psychiatric outpatient clinics have the training and expertise in taking in like hundreds of trauma victims. I've worked 15 years in child psychiatry, and I never had any training for that. I know how to train and how to reach out to parents with children of autism and ADHD and suicidal youth and all that, but not trauma victims the first day. So then they would certainly need training.
Yeah.
Long comment, sorry.
That's okay. Yeah.
Thank you for an interesting day. I was just wondering, you partly started on it, but I mean, in a way, what you just presented for us is not very uplifting, right? It doesn't really make any sense whether if we do anything or not. The people you saw had PTSD in the aftermath soon after, still have it after a while. The perfect setup with free psychological care didn't seem to do a lot. The nice outreach with these ideal settings outside of the clinic didn't help either. So what I would really like was to hear from you, based on all your experiences, what do you really think would be the best setup?
What you're saying is not correct. We don't know if psychiatric help actually helped them. We have looked at it in the big picture, like the whole group. We haven't looked at people who got 2 interventions compared to those who had a lot more, like 40 or more. So we have to look at that. But if you saw Sarah's slides, you know, the ones that went at 3 years, it didn't matter. But in the meanwhile, those that got the right interventions, the interventions we see help, they had a lot less PTSD over time. And
I'm aware of that. They got better, quicker than the others. So I'm also over-exaggerating a bit, sorry for that.
Yeah,
but I'm still curious to hear how, I mean, when I came here this morning, if people had asked me, I would say something about psychosocial aid, I would say a lot about outreach and those things, and now I'm a little bit like, it doesn't seem to be as efficient as at least I happen to believe when I came here this morning.
You want to have the answers.
I mean, you're the experts, right?
That's why we need these conferences, because there's a lot of unanswered questions.
Perhaps I can sort of say to that that outreach is essential, but it's not the whole picture. You have to follow through and make sure that the outreach results in the right things happening. And it's only when there's outreach plus evidence-based treatment and appropriate treatment that you can expect to see a result. And I think that's something that Grete is going to follow up on and see exactly what happened, because in London we know what sort of treatment they got, but in most other studies we don't really know. So that will be the critical thing. But
yeah. And then to reach the right people, that's, at least for me, one of the outstanding things from your lectures today. How do we do that?
But I think we all have answers to it, I think there's a lot of, like I said, the hierarchy of knowledge. I'm really serious about it, even though it's a silly figure, But I think we need knowledge on the high level, RCT studies, but we also need the knowledge that comes from you out in the field. What is going on in the field when you try to implement this knowledge into practice, where you are? How is it working then? And as I said to you, the messages from specialized mental health care services have been like silence. Don't hear anything, So we need more communication between research and clinical practice to develop this further.
Maybe we also need a study about the organizational barriers and problems with communication. Why is it so? And how much does that destroy or impede the progress in the field?
Yeah. I think as Denmark ends up with this model for the acute interventions, it will be something really different from our way of doing it. So I will be curious to see what we can gain from the different ways of doing it, if this is the way you're going to implement it. But I'm not so. I'm curious to see what it is in practice.
Yeah, I don't have the answers. I think I have some evidence that shows a lot of problems, and I think that we, together with the Board of Health and with the regions, should try to develop models that are more efficient.
Yeah. You see, in Norway, the health authorities have now, I think, more than 1,600 new psychologists last year in municipalities. So it's also about what kind of people you staff into the municipality system, and where the change is between the municipality system and specialized mental health care. Where do you want to draw the line? So that can also be a difference in the systems. That's maybe why I don't understand why. Maybe you have more people into specialized mental health care and less specialized people in the community-based system, while we go the other way. Yeah. There's a lot of talk about in Norway to low thresholds for getting help and getting help easy, not having to have referrals to mental health because we have this long waiting list there. Yeah. So.
Hi. So taking into account all that's been said today, what kind of intervention, if any, would you suggest using if, say, a company has a smaller accident, somebody gets seriously wounded or maybe dies on work, there's, say, 12, maybe 15 people who are witnessing this or in connection to this, what kind of intervention would you suggest doing, if any?
Well, I think what most companies will do due to their insurances is that they will call the FALC emergency company, have fact psychologists coming out, they'll do some debriefing. Maybe they'll come back after some days or 1 week and will follow someone in the staff who are specific vulnerable, may take care that they get some referral to a sygesikringspsykolog or some other help services. That's what most likely will happen.
Et sådant spørgsmål, hvad du husker, eller hvad vil du have?
Yeah, so that's most likely what would happen. So what do you suggest should happen? And also I'd like to hear the others if I can.
I think one of the most important thing, I think, is the organisation acknowledges what's happened and the severity of the incident, so that you have concern shown by management and about exactly the impact that there might be on the employees. They need information and they need reassurance that if they do have a bad reaction to it, then they will get proper help for that. So I think that requires information about how they might respond, what kinds of treatment are available if they do have persistent problems, and access to that treatment that has a proper evidence base. So I would see those as the sort of three essential things, and that the organisation remains concerned and in contact with those individuals, and that they feel it's going to be easy for them to report problems without being penalised and punished by the organisation because they're not working as effectively as perhaps they were before.
I totally agree. I think it's a lot about information, knowledge, and being there for them, reaching out to them. And as Chris said, for a working place, it's a lot about the organization of the leadership. The leadership takes the lead also in this work. So they don't say like, oh, this is human relations, that's that department. We don't have anything to do with it. We go forward. Everybody has to be included, and the leadership has to take leadership in this situation. It might also be a school, a school shooting, for instance. It's everybody's problem. It's not only the problem of those 10 with the most symptoms. It's everybody's problem. So we have to solve this together. But in the first phase, it's a lot about information. People want to know what happened because everybody has to make a meaning out of this event. And each person will have to do that themselves. And then there can be a lot of gaps in what was going on with me, And to getting that narrative going, you may need help. And then that help has to be available. But that can be really different from person to person. And some need it the first day, the others need it 10 days after. Some cannot sleep. So a lot of people cannot sleep after these events. That's really important. I just had a very heartbreaking narrative from one of the survivors at Utøya that described how she functioned the first week. She couldn't eat. Her mother had to feed her. She couldn't sleep. She couldn't read. She couldn't hear music. She couldn't see. Her hearing was impacted. So totally like a patient after a severe accident where you have physical injuries. And that family didn't get any help. So then you can imagine what kind of help do you need then? There is not a formula for that. But there has to be people available so you can seek help when you need it. It's a very, very diverse reactions.
I would like to add two things. One is that the need for information about what happened. In the case you're talking about, there will be different perspectives from the other workers, and it could be very useful for each individual to know about the other perspectives, to make a more complete picture of what happened during the accident and later on also. And the second thing is that you should also consider having some kind of services for the spouses, maybe also for the children, because the workers that has been impacted, they will also bring their problems at home. So it could be very efficient to do something for the families in one way or the other.
Yeah.
So what I'm hearing you saying is you're actually still talking about maybe actually doing a debriefing, but I'm more unsure about what your colleagues would suggest doing about that, because the whole, from my perspective, doing a psychological debriefing actually also consists of, or defusing for that matter, consists of putting the information pieces together about the event, and that's, my own experience is that is quite helpful for people. But then again, there are all these other considerations about cost efficiency and whether or not it might also be give a negative results for some of the participants if you force them into a group session as a debriefing.
Yes, I think you never know what's going to happen in a group debriefing. Some people are going to be reassured and the information is going to be helpful. For other people, they may be disturbed by what they hear and other people's reactions. So I think it's introducing uncertainty where perhaps you don't need to introduce uncertainty. But I think if people have a need for information, then you should certainly, it's good to try to respond to that. And if they want to know, how did this happen, then the organisation needs to find a way of getting that information and telling them. So, but I think it's in a way that is each individual can approach it from their own perspective, rather than saying this is what you need to do, or we will tell you how to go about getting better.
Yeah, I think in all group dynamics you have that problem, isn't it? That you come there to get better and try to get rid of all your bad problems, but you get all the others' problems exposed to you, and that can be a problem sometimes. But I think there's a difference in the groups. It depends what group you are talking about, because if there's a group that has been briefed for something, they go out and do it, then getting a debriefing is different than a group that's just exposed to something. So if you're talking about ambulance personnel or fire workers or police or others, I think it's different. You are briefed to do a task or something, and then you come back. And then going through that event and what went wrong and what did not go wrong is, as I see it, different from emotional debriefing in a group. Do you agree? I don't know if you think the same way, but...
You will ask him afterwards, because we have to stop now.
Yeah, sorry.
I'll just say a few words.
I'm not a debriefing specialist, by the way, so...
Yeah. I cordially want to thank our speakers for coming here and for sharing with us the very informative presentations. They have given us what we wanted and needed of inspiration so that we can push on to reach a higher level of preparedness so that future disasters and terror situations will have well-organized, well-trained and well-performed psychosocial interventions that use evidence-based methods and monitor the progress of the procedures. So shall we give them a hand? I also want to thank the audience for being engaged, and all of you are welcome to contact us for follow-up activities. The power presentations will be available on the website, and so will the video recording. We will make proposals and initiate talks with the Ministry of Health and with the regions, and you can follow that work on our website. And I want once more to thank the Obelske Family Foundation for their support, and I also want to thank the assistants for the hard work they have done to make this day a success. So thank you all. I wish you a safe journey home.